Hello, my name is Rhanishia. I am a family nurse practitioner and currently in my last semester of my doctorate program at Baylor University studying to become a nurse midwife. I thought it was so important to create this course for you because of its importance in women's health. When you get to the root of so many disorders affecting women, you will find yourself going back to the root of the HPO axis or the hypothalamic ovarian axis. I'm excited to teach you both some new topics as well as review some familiar topics as they relate to the menstrual cycle. Please read this legal disclaimer. I thought it was important to create a course that helps you to master the menstrual cycle because it is my belief that if you understand how to properly assess and diagnose menstrual irregularities, you are able to help women overcome many acute and chronic issues. But I also believe that when you can confidently both understand and teach the negative feedback loop that is presented in the menstrual cycle, you understand how the brain interacts with various hormones and the reproductive organs. You will become empowered to better care for the women who present with health conditions that once seemed intimidating. You may have encountered women that present with symptoms that made you think instantly, she needs to see a specialist. Imagine your practice being impacted in a way where you gain the confidence to order specific tests and diagnostic procedures that confirm your suspicions before transferring care where that individual has to start all over again, where she has to build rapport with the new provider, explain her story over and over again, repeating labs and expensive tests just that she maybe didn't need. And because you understood the basis of her reported history and her presenting symptoms, you were able to apply some of the differential diagnosing that you will learn in this course. So thank you for joining, and I hope you find value in this course. The hypothalamic ovarian axis, or HPO axis, is a tightly regulated system which controls female reproduction. It coordinates the production of hormones essential for procreation, including gonadotropin and steroid hormones. They do so in a cyclic manner. I want you to take a closer look at this picture here on the screen. You see the hypothalamus situated right at the base of the brain near the center. Well, that structure of the brain, in fact, is the central control center for regulating reproductive hormones. Now, take a look at the boxes. Each of those boxes lists the hormones that are very important for this lecture. You can see also in this photo in pink, the pituitary and the ovaries also making up this system, all working together to coordinate hormones for procreation. The pituitary gland is also located at the base of the brain, just below the hypothalamus. This gland is often referred to as the master gland. So keep that in mind throughout this lecture. The hypothalamus, or the control center, and the pituitary gland, or the master. Can you recall that picture of the boxes that list those hormones? Now let's discuss them. Follicle stimulating hormone, or FSH, is a hormone produced by the pituitary gland in the brain. It plays a key role in the reproductive system by stimulating the production of estradiol. FSH achieves this by enhancing the synthesis of the enzyme P450. FSH stimulates the production of receptors for luteinizing hormone, or LH, on the surface of granulosa cells. Granulosa cells are a type of specialized cell found within the ovaries. As a result, these granulosa cells become more sensitive and responsive to LH. This enhanced responsiveness to LH is an important step in the process of ovulation. So during the menstrual cycle, the increase in FSH levels causes ovarian follicles to develop and grow. As the follicles mature, they produce more LH receptors on those granulosa cells. When the LH surge occurs, triggering by a rise in estrogen levels, it can now efficiently bind to these LH receptors. This LH surge is what ultimately triggers the release of a mature egg, which is ovulation. So, FSH induction of LH, receptor synthesis, is a critical step in preparing the ovarian follicles for ovulation and ensuring that the LH surge can effectively trigger this process. FSH levels in the blood can vary widely depending on various factors. In normal circumstances, during pregnancy, FSH levels can be as low as 0.1, depending on things like age, pregnancy status, and the stage of the menstrual cycle. In women with regular menstrual cycles, those FSH levels typically range from 1.4 to 9.9 during the first half of the menstrual cycle. As you can see on this chart here, they rise to around 17.2 during ovulation. During pregnancy, FSH levels drop significantly to about less than 0.1. FSH levels decrease during pregnancy due to the action of HCG. This takes on some of the role of LH and FSH in regulating the reproductive system. So this hormonal control is crucial for maintaining the pregnancy and preventing ovulation during gestation. Women approaching menopause may experience a varying in the FSH levels based on menstrual cycle irregularity. Once menopause is reached, FSH levels rise considerably, often exceeding 30, and sometimes even exceeding 100. This rise in FSH during menopause is a consequence of declining ovarian function, decreased estrogen production, and the body's attempt to stimulate the ovaries, which are no longer capable of responding as they did during a woman's reproductive years. Elevated FSH levels are a hallmark sign of the transition into menopause. Listed here are some general guidelines for normal LH levels in women at different stages of the menstrual cycle. Weeks 1 and 2 of the cycle, typically LH levels range from 1.37 to 9 international units per liter. In week 2, before ovulation, LH levels are usually high, ranging from 6.17 to 17.2. And in weeks 3 and 4 in the cycle, 1.09 to 9.2. And again, post-menopausal women, LH levels can be higher, ranging from 19.3 to 100.6. So remember, the follicle in follicle stimulating hormone. FSH helps the ovarian follicles to develop and grow. Luteinizing hormone will help the ovaries to release estrogen. That estrogen is what triggers the LH surge. The LH surge is what ultimately triggers the ovaries to release that mature egg. Estradiol is a primary steroidal hormone, which plays several key roles in the female reproductive system. It stimulates breast development and the growth of the skeleton, contributing to pubertal growth acceleration. In later stages of puberty, estradiol, along with the secretion of hormones from the pituitary gland, your FSH and LH, is essential for ovulation and the initiation of menstrual cycles. Estradiol has a positive feedback effect on the pituitary gland with LH. Here's how. As estradiol levels rise, they have a positive effect on the pituitary gland. This positive feedback, it stimulates the pituitary gland to release more LH, ultimately trigger the release of a mature egg. Again, to summarize, as estradiol levels rise, follicles mature, and hopefully leading to a release of a mature egg in preparation for pregnancy. What are the normal estradiol levels? 30 to 400 for premenopausal women and 0 to 30 for postmenopausal women. Lower results could suggest ovarian failure or low estrogen due to factors such as rapid weight loss or anorexia. Higher levels may indicate the presence of a tumor in the ovaries or adrenal glands. Progesterone, in conjunction with estradiol, affects certain neurons in the hypothalamus, specifically those responsible for secreting GnRH or gonadotropin releasing hormone. In the last slide, I talked about the positive feedback loop. Well, progesterone negatively modulates GnRH secretion. This leads to a reduction in both FSH and a more substantial inhibition of LH secretion. Progesterone is a hormone that predominates during the luteal phase of the menstrual cycle. It plays a crucial role in maintaining the uterine lining during the later part of the cycle and throughout pregnancy. Progesterone levels can vary based on the lab that is used for testing, as well as factors such as the timing of the test within the menstrual cycle or whether a person has reached menopause. The normal ranges are listed here. Over the next few slides, we will go a little further into the negative feedback loop. This is a very important concept to understand in the HPO axis. An average menstrual cycle is typically considered to be around 28 days in length, although average can vary from person to person. The menstrual cycle is counted from the first day of one's menstrual period to the day before the start of the next period. However, it is important to note that menstrual cycle lengths can range from 28 to 35 days and still be considered within the normal range. The follicular phase begins on the first day of menstruation and lasts until ovulation, typically days 1 through 13. During this time, ovarian follicles develop and the uterine lining begins to thicken. At the beginning of a new menstrual cycle, there is minimal ovarian hormone production, and the follicles begin to develop independently of those gonadotropins or ovarian steroids. This results in low levels of steroids and inhibin, which have limited negative feedback on the HPO axis. As a result, FSH and LH levels increase, stimulating follicle growth and estrogen production. The initial phase, it sets the stage for the development of ovarian follicles and the subsequent hormonal changes in the menstrual cycle. Only one dominant follicle can continue to mature and complete its development. As estrogen levels rise within this dominant follicle, the negative feedback mechanism, it reduces FSH. This reduction ensures only the dominant follicle survives, which others typically degenerate or form polar bodies. Once follicular estrogen levels reach a certain threshold, they initiate a positive feedback within the HPO axis. This results in an increased level of GnRH and gonadotropins, specifically LH or luteinizing hormone. Importantly, this positive feedback primarily affects LH levels and selectively inhibits FSH production at the anterior pituitary gland. As a result of this hormonal shift, granulosa cells within the dominant follicle undergoes luteinization and express receptors for LH. This prepares the follicle for ovulation and the subsequent formation of the corpus luteum, which is essential for the production of progesterone during the later half of the menstrual cycle. As mentioned before, progesterone is the hormone that maintains the pregnancy, hence the need for production during the later half of the cycle. During the luteal phase, or the second half of the menstrual cycle, the corpus luteum forms in the ovary at the site of the ruptured follicle following ovulation. This specialized tissue, it produces hormones including estrogens, progesterone, and inhibin to maintain optimal conditions for fertilization and implementation of that fertilized egg within the uterine lining. The corpus luteum's hormonal activity is crucial for preparing and sustaining the uterine environment for potential pregnancy during this phase of the menstrual cycle. At the end of the menstrual cycle, in the absence of fertilization, that corpus luteum naturally regresses after approximately 14 days. This regression results in a significant decline in hormone production, which alleviates that negative feedback mechanism, and it resets the HPO axis, preparing it for the start of a new menstrual cycle. However, if fertilization does occur, the trophoblast of that developing embryo begins to produce HCG. HCG exerts a luteinizing effect on that corpus luteum, preventing it from regressing and helping it to maintain its hormone production to support the early stages of pregnancy. The placental HCG, it further supports the corpus luteum and produces hormones necessary for sustaining the pregnancy. As the pregnancy progresses, typically around 4 months of gestation, the placenta becomes capable of independently producing sufficient steroid hormones to regulate the HPO axis. So basically, at this point, the placenta takes over, reducing the dependence of the corpus luteum for hormonal support. This transition is a significant development in the hormonal control of pregnancy. Let's quickly recap how these 4 hormones play special roles in each phase of the menstrual cycle. FSH stimulates the development of eggs within ovarian follicles and promotes the release of estrogen. LH stimulates the release of a mature egg or ovulation and plays a role in the production of estrogen and progesterone. Estrogen is responsible for the growth and thickening of that uterine lining. Estrogen also inhibits FSH, stimulates LH to trigger ovulation, and then inhibits LH after ovulation has occurred. Progesterone maintains the uterine lining to prepare it for the potential implantation of a fertilized egg. It also inhibits LH after ovulation, helping to regulate the menstrual cycle. We have covered a ton. I think you all now understand how the HPO axis work, right? Let's shift gears and discuss some common causes for disruption of the HPO axis. Hypothalamic pituitary failure refers to a condition in which a woman lacks one or more of the pituitary hormones. These hormone deficiencies can disrupt various essential functions within the body, including growth, blood pressure regulation, and reproduction. The specific symptoms experienced by an individual with this condition will vary depending on which hormone or hormones that are deficient. Eugonadal ovulatory dysfunction refers to a condition in which a person's reproductive system, including the ovaries, appear to be functioning normally, but there is a disruption in the normal ovulation process. Therefore, eugonadal is normal. One common example of eugonadal ovulatory dysfunction is PCOS, or polycystic ovarian syndrome. This is where individuals often have structurally normal ovaries but may experience irregular ovulation due to hormonal imbalances. Weight and body fat distribution plays a significant role in the regulation of ovulation. In the context of PCOS, weight loss has been demonstrated to reduce androgen levels in women with PCOS. Even a modest reduction in body weight, as little as 5%, can lead to the return of regular menstrual cycles. Obesity is linked to chronic anovulation or a lack of ovulation, independent of PCOS, highlighting the impact of weight on the reproductive health. Hyperprolactinemia. This is a condition that is characterized by elevated levels of prolactin in the blood and is closely related to dysfunction in the HPO axis. Prolactin is a hormone primarily produced by the anterior pituitary gland and is regulated by the hypothalamus. High prolactin levels can suppress that secretion of GnRH from the hypothalamus, which subsequently affects the release of FSH and LH from the pituitary gland. This disruption can lead to irregular menstrual cycles, including amenorrhea or an absence of menstruation, and anovulation or a lack of ovulation, and fertility. There's changes in the estrogen and progestin levels. In ovarian failure, there is a disruption to the HPO axis by causing the ovaries to malfunction, resulting in reduced ovarian reserve, which can lead to infertility. Ovarian failure can result in low levels of estrogen and progesterone, leading to, again, menstrual irregularities, amenorrhea, and other symptoms of hormonal imbalance. Since the ovaries are not functioning properly, ovulation might not occur regularly, making it difficult for women with OF or ovarian failure to conceive naturally. Common acquired causes of this disruption of the HPO axis may include autoimmune factors, which may involve genetics or environmental factors. They can lead to an accumulation of dendritic cells and an excessive number of lymphocytes, resulting in tissue damage. Some evidence suggests an association between POF or premature ovarian failure and conditions such as lymphocytic uveitis and other autoimmune disorders. Anti-ovarian antibodies have been reported in cases of POF, but their specificity and exact role in the development of the condition remains unclear. Some iatrogenic causes of HPO axis disruption may include chemotherapy and radiation, certain surgical procedures, especially those involved in the removal of the ovaries, or damage to the hypothalamus or pituitary gland. The use of hormonal therapies, such as hormone contraceptives or hormone replacement therapy, can temporarily affect the HPO axis while the meds are being used. Discontinuing these medications usually restore normal hormonal function. Some intrauterine devices, particularly those that release hormones, can impact this axis by altering the menstrual patterns and hormone levels. Some medications, such as certain antidepressants, antipsychotics, and medication used for chronic conditions, can also affect hormonal regulation. Rapid weight loss or excessive exercise can lead to changes in hormone levels. You often see this in conditions like the female athlete triad. And lastly, extreme stress, such as physical or emotional trauma, can disrupt the HPO axis temporarily, also leading to menstrual irregularities. Ovarian failure can also be age-related, linked to changes in the HPO axis as the aging ovaries and hormonal shift affects the regulation of the menstrual cycle, ovulation, and overall reproductive function. These changes are part of the natural aging process and are a key factor in age-related infertility. While primary ovarian insufficiency is more common in older women, it is possible for younger women, including teenagers, to experience this condition. The diagnosis of POI can have significant emotional and reproductive implications, therefore making early detection and intervention essential for all those who are affected. In conclusion, the hypothalamic pituitary ovarian axis is a coordinated system essential for procreation. It regulates the cyclic production of gonadotropin and steroid hormones. The ovaries normally produce a dominant follicle, leading to a single ovulation each menstrual cycle. This process is tightly regulated by gonadotropic hormones, which is FSH and LH, to select a dominant follicle and prepare the uterine lining for implantation. The ovaries also produce crucial steroid hormones for follicular development and egg maturation. 4 major hormones, FSH, LH, estradiol, and progesterone, are monitored during the menstrual cycle. A properly functioning HPL axis is essential for a regular menstrual cycle, and dysfunction in this system can lead to ovulatory disorders, which are a leading cause of infertility.